Okay.
Are we live?
Yes.
1 second. I think the slides are still loading. Dan,
okay.
do you want to? Oh.
Ryan, I'm just going to share my screen.
Yeah, go for it.
Click. All right. Hello, everybody. I believe we're live right now. So yeah, just I'm down from the BMA. I was going to say just a couple of minutes before we start today. Yeah, obviously pretty big. Another big year for what's going on in terms of pay. All around, juniors, consultants, SAS now as well. So most of you guys watching, I'm sure, final years. So yeah, I guess the main message from me is it's just pivotal that we continue what's been going on and the great effort that everyone's been putting in. It continues into your year group. So yeah, big messages. If you're not a member, join the BMA. Usually when you go online, you start paying straight away, so it's £3.75 a month. But I'm doing a little bit of a deal for those watching Mind the Bleeps, that if you join using this QR code on the screen, you get a £10 Amazon voucher for joining. So because it's £3.75 a month, it works out as about getting 3 months free basically through the Amazon voucher. So scan that QR code if you're not already a member, and then drop me an email when you've done so, and I'll get an Amazon voucher sent out to you. The more members we have, the better basically, and we just want to show that the next the next year group coming through into F1 are going to be strong and on it as much as the years, the 2 years now the past as F1s. So yeah, a little bit about that, a little bit about membership in general, and sort of benefits that you can be using now as well. So yeah, hopefully everyone knows what the BMA is now. Sometimes we get a little bit of confusion between us and companies like MDU and MPS. So they're indemnity companies. So if you were to accidentally cut a patient, that would be where you deal with MDU, MPS. We're your union, so we're things like your pay, your contracts, and that kind of thing. So we actually negotiate the contracts for better for worse in the UK, and that's why a lot of what's going on now is happening. BMA, unlike other unions like Unison, whatnot, the BMA is purely for doctors and med students who are going to become doctors. So yeah, our membership at the moment is 191,000. So that's just doctors and medical students across the UK, and that's most people are members. So yeah, so do join, become part of. Well, it's the biggest membership I've known in my time at the BMA, which is nearly 10 years. So yeah, we're going from strength to strength at the moment, and it just shows the power that we can have if we all come together. So yeah, so a little bit on junior doctor pay. I'm sure you guys know what's going on. Maybe you've been down to the pickets yourselves, but yeah, it continues basically. We don't know how. I'm hoping this is the year that things end. I mean, I've started to think that the current government are just waiting for general election to come along to sort of sort things and maybe pass the buck. So I don't know. I sort of get the news in real time as everyone else gets it, so I don't really have anything secret to tell you. I imagine that the next round of strikes will probably be mid-February. You can sort of make a guess based on the patterns of the past. It seems to be sort of once a month and a couple of days. So I'm imagining next strikes might be mid-February for juniors. So yeah, any news we get, you'll be first to know, as I am. And I asked this question today in terms of final years, and if there was an offer put out, would final years be able to vote on it? And I think the precedent is that it would include final years, as obviously you'll be going on to that contract, and potentially also penultimate years. So yeah, only people that will be in membership can vote on that deal. So another reason to sort of be involved. So things that you can use right now, if this is coming to you sort of the end of your med school life, I'm sorry, I wish you'd known this the whole time. But yeah, BMA library, we used to have sorry, every book you could imagine under the sun in BMA House in central London. We would post the books out, but now we just moved everything online so everyone can get everything instantly. You can just go on there, search exactly what you need, any journals, textbooks, and you'll be able to open it instantly through the website. BMJ Learning, great for exam revision and the like. So you may get BMJ Learning through the med school as is, but this will be you'll have no paywalls of this. You'll have complete access, obviously, to BMJ Learning, and all this is obviously included in the £3.75 a month. Clinical Key, great point of care tool. If you've never used it, it's worth downloading the app and logging in with your BMA membership. Again, you type in any condition you can think of, and it'll bring up every single journal, textbook, video that could possibly do with that condition. BMJ, the BMJ itself. Oh, I can hear something. The BMJ itself. So the magazine. As your final years, this is a bit of an if you know sort of thing. As your final years, you're actually entitled to get the BMJ through the post every week, so the doctor's version rather than the student version, which is down to once a year. So yeah, so 4 times a month, I get them on Fridays. You're entitled to get that BMJ, but you just have to opt in. So if you just give us a phone call on that number, bottom right of the screen, or just on our general email, support@bma.org.uk, we'll start sending those to you. And just make sure your address is correct. So yeah, that's part of the £3.75 a month. So even if that's the only thing you sort of used on the BMA, that's less than £1 a copy delivered to your door. So definitely worth joining. We've got a great wellbeing support service. This is open to everybody, regardless of whether you're a member or not, and it's open 24/7. And the pretty unique thing about this is it's you have the choice of speaking to a counsellor or a peer support doctor, so somebody who's been through medical school, who's had similar experiences, perhaps. Specialty Explorer, maybe early to be talking about this, but we've got a really good Specialty Explorer tool. Basically, it's 20-minute psychometric test. It'll ask you all sorts of work-life balance questions, and then at the end, it will give you a breakdown in what specialties would suit you according to the answer you've given. Really good to do it sort of now, and then during F1, F2, and so by the time it comes to choosing your specialty, this has sort of guided you a little bit. Gives you lots of breakdowns and diagrams and graphs to show why such specialties would suit you. So yeah, really interesting tool, worth using if you've not used it before. That's it. Try to be as brief as possible. This is going to be a pivotal year. Obviously, you guys starting F1 this year is coinciding with what's going on with the strikes. So yeah, just be as involved as you can be, and definitely be a membership. Yeah, and at least get something for joining as well. Like I said, if you go online, you don't get anything for joining, but because you're watching this, you can get a £10 Amazon voucher. So make the most of it. Cool. I'll let you get on with the session. Thanks for listening, and then just keep your eyes peeled with everything that's going on or not going on. It seems at the moment with the government. Yeah. Thanks for listening.
Thanks, Dan. So hi everyone. My name is Nimesh. I am I'm a junior doctor in Birmingham QE Hospital at the moment, and we're going to be presenting the Ophthalmology final series lecture today. Myself and Cameron, who's a doctor in Australia. Cameron, do you want to say hi?
Hi there, guys. I'm a doctor, just finished F2, now working in Australia, and yeah, looking forward to the talk tonight.
Okay, cool. All right, so without further ado, let's get started. So essentially, in this lecture, we're kind of going to go through most of your core conditions, essentially, which you guys probably have, at this point, have had a look at from the UK MLA curriculum map. So we'll be firstly going through a quick recap of anatomy, then a quick revision of the eye examination. So not too much depth, but just a quick revision of that, and then we'll be moving on to the sort of red eye conditions, and then visual loss, as well as a few other presentations as well. Okay, so next we'll go on to the recap, the anatomy recap first of all. So essentially, to understand kind of different conditions, I think it's always good to have a good basis of your eye anatomy. So essentially, we've got 3 layers. The first layer is kind of your fibrous layer on the outside, which consists of the cornea and the sclera, and which are both continuous with each other. So the function of the cornea is it does the majority of the refraction actually, and kind of focuses the light on the retina. And then you've got the sclera, which is capsule, which provides some structure to the eye and also allows attachment of your extraocular muscles, allowing for eye movement. Next, and all of this is avascular. And next, we've got the vascular layer, which kind of provides the nutrients and everything for the eye, which is the choroid, the ciliary body, and also the iris. And collectively, that whole thing is called the iris, ciliary body, and choroid are all called the uvea. And what the choroid does in particular, it's full of blood vessels, and it kind of supplies the retina with essentially all the nutrients it needs. Then we've got the iris, which controls your pupil, and that consists of circular muscle and a radial muscle, and the contraction of that causes the contraction of those muscles cause pupillary constriction. Fine, and then from there we move on to the ciliary body, which essentially consists of muscles which attach to the lens with processes, and the function of this is essentially to control the thickness of the lens, and again that helps with the refraction of the light onto the retina. And also the ciliary body makes some aqueous humor as well. Right, so we've gone through two of the layers, and the final layer is your retina, which is the photosensitive layer. And you kind of got your neural part of the retina, which contains your photoreceptors, which go to your bipolar neurons, go to the ganglion cells, and then that sort of signal gets transmitted to the optic nerve, and that eventually goes to the thalamus in the brain. And you see, so that's your neural layer, but you've also got a pigmented layer within the retina, which essentially allows for absorption of light and prevents light from kind of bouncing around in the retina, causing a distortion of vision. So those are the kind of two layers in the retina. And within the retina, there's certain areas that we need to be aware of. So we've got the macula, which is the central portion of the retina, and it's where you have a high resolution of color vision. And within the macula, you've got the little pit, which is called the fovea. And that's where you have the highest concentration of cone cells in particular, which provide the sharpest visual acuity. And finally, we've got the blind spot, which is where the optic disc is. And that's kind of where all the vessels converge and your optic nerve is, and goes off from there, basically. And just in terms of your chambers, the anterior chamber, which is kind of between the cornea and the iris, and that contains the aqueous humor. And then you've got the posterior chamber, which has the vitreous humor, and you might have a sort of remnant, embryological remnant, which is the hyaloid canal, which is there as well. All right, so that's a brief recap. And one more thing I forgot to mention actually is you have a layer on top of the sclera, which is conjunctiva, which is kind of like a see-through layer on top as well. All right, so from there, let's go briefly through the eye examination. So I kind of like to think of it as having a general inspection of the eye, and then you kind of move on to your sort of tests. So in terms of your general inspection, we've got you're going to inspect, I like to think of it as you inspect the periorbital regions, then you move on to the eyelids, and then the eyes itself. So including the pupils when you move on to the eyes. So certain abnormalities that you might want to mention and pick up on or pay attention to when you're doing a general inspection are things like swelling, redness, discharge, any prominence of the eyes, so if one eye is particularly popping out more than the other. Also abnormal eyelid position, so any drooping, ptosis, And we'll talk a little bit more about all these and the relevance of all these signs a little bit later. And also, you want to note the shape, size, and asymmetry of the pupils as well when you're doing a general inspection. So general pupil inspection is involved in this. So in terms of the kind of your special tests or the sort of structure of your examination, you can remember it as AFROB-C, which is kind of how I remembered it. So you got your visual acuity that you want to test first, and then you got your visual fields. Then you move on to your reflexes, so your direct, consensual, and accommodation reflexes. Then you get the ophthalmoscopy or fundoscopy. And finally, don't forget to test for the blind spot. So some people kind of miss this, but you can kind of mention it within your examination. So, and finally, you've got the C, which is your color vision. And kind of you use the Ishihara plates here. So we'll briefly talk about the visual acuity assessment. So when you're assessing visual acuity, you can use either the Snellen chart or a logMAR chart, and you ask the patient to essentially stand 6 meters away. You want to test each eye separately, and you want the best vision, their best corrected vision, essentially. So you want their glasses on, and you ask them to read as far down as possible, starting from the top, making their way down, and record essentially the lowest readable line. And if the vision, and then if they have decreased visual acuity in comparison to previous tests, then you can use a pinhole which can identify whether they have a refractive error or not. And the reason why the pinhole works is because if they have a refractive error, and you use the pinhole, you're kind of directing the light directly through the center of the lens, which has the area of like least refraction, and it goes straight onto the back of the eye, onto the macula and fovea, so the place of highest visual acuity. And that will hopefully, if it's just a refractive error that can be corrected with glasses, that will kind of correct whatever error that they might have. And so, as it says here, normal eyesight is essentially 6/6 or 20/20 vision. And just in terms of the numbers and the presentation of it, or of the visual acuity, you can present it as the numerator, which is the distance that the patient is actually standing away from the chart, so 6 at the top. And then you've got the denominator, which is the distance at which a normal eye would be able to read the last line that the patient has read up to. So it's a bit confusing unless we take an example. So, for example, if a patient has a vision of 6/9 and -2, it would mean that the patient can essentially read up to the letter O on the chart. So that would be they would essentially be able to read, they would essentially be standing 6 meters away, but are only able to read up to the line which a normal eye should be able to read at 9 meters away, if that makes sense. And the -2 is just means that it essentially tells you how far along the line they're able to read. So they're able to read up to the 9th line -2 letters. So that'll be the O. Okay, so that's pretty much what you kind of need to know from here. So next we'll move on to visual fields testing. So I'm pretty sure all of you guys will have gone through this during your cranial nerves examination, but just a quick recap. A few points to note when you're examining each eye. Make sure you're mirroring the patient when you're asking them to cover one eye. You mirror them, and then you kind of use either wiggling fingers or I think it's a hat pin to kind of measure the visual fields there, and you kind of work your way inwards. And generally, when doing visual fields assessment, I try to ask the patient I try to do a gross assessment. So ask if there's any parts of my face missing, first of all, that you would ask to tell any gross abnormalities. And then you would move on to the kind of fine adjustments, so using the wiggling fingers and moving your sitting equidistant away from the patient, and kind of moving your fingers inwards and comparing when they see the finger or the hat pin compared to when you kind of see the fingers or the hat pin. Okay. And also, there's also automated perimetry, which you can also mention, which essentially gives you a better assessment of the patient's visual field. So next, we've got the assessment of pupils. So when you're assessing the pupils, as I mentioned, talk about size, symmetry, color, and shape. We'll talk a bit more about the relevance there later. And you also want to assess for the reflexes here of the pupil. So you want to assess the direct light reflex, the direct reflex, and also the concentric light reflex. So the direct light reflex is essentially when you shine light into someone's eye, that pupil will constrict. Concentric light reflex, the other pupil will constrict as well. And that is essentially because whatever sort of signals that one eye gets, the afferent pathway kind of takes it all the way back into the into the brain, into the Edinger-Westphal nucleus, and there's a crossover of the pathways here. So whatever you perceive in one eye, the effect that causes and the signals that are sent out from whatever signals that you receive are sent out to both eyes. So both eyes will either constrict or both eyes will dilate because of the crossover in signals. Don't worry too much about this diagram. It's just to show you that there's a crossover of signals. So both sides of the brain receive the signals from each eye, and that kind of affects both eyes equally. So having said that, we'll talk about RAPD very briefly. So because of the bilateral sensory innervation of the Edinger-Westphal nucleus, if you shine a light in one eye, both eyes should constrict. In RAPD, there's a unilateral defect in the afferent pathway, so the signals coming from one of the eyes, and because of that, the other eye might be, and the other eye is essentially normal or lesser affected. And this, remember, it's a relative effect. So if one eye is seen to have a defect, it's relative to the other eye. Doesn't mean the other eye is completely normal. It just might have a lesser defect. And essentially, the efferent pathway is intact, but it's the afferent pathway that's kind of affected here. And so what happens when you have an RAPD is that if you shine a light in the affected eye, if you shine a light in the not unaffected eye, the affected eye will be able to constrict because there is because the efferent pathway is intact. Whereas if you shine the light, swing it to the other side, and you shine it in the affected eye, then you'll see the affected eye will be dilated, or it won't really react to the light, and you won't see a reaction in the unaffected eye as well. Okay. All right. So move on to the fundoscopy or ophthalmoscopy. So here. One second. Yeah. So we'll move on to fundoscopy. So essentially what you want to do with fundoscopy, assess, generally when you're doing fundoscopy, you want to be in a dim or dark room to try and get the patient's eyes as dilated as possible so you got a good view. Then you find the red light reflex, so stand at approximately 45 degrees to them, maybe a little less, and then follow the red light reflex in, or red reflex in, and you should be able to see the back of the eye. And then from there, you will be able to identify the vessels of the eye, and then you kind of work your way from the vessels towards the optic disc. And in terms of what you're commenting on, or what you're trying to observe with the optic disc in particular, you're trying to observe the cup color and contour. So with the borders of the borders of the optic disc should be quite clear and well defined, and it should look kind of orangey pink, like a donut sort of thing. And you want to comment on the cup to disc ratio as well. So this is shown quite nicely in the diagram there. So you got the cup on the inside and you've got the disc on the outside, and that ratio should be 0.3. And we'll talk about the significance of the ratio being higher, or around approximately 1, a little bit later on. And finally, when you're assessing the retina, you want to assess it in quadrants. You want to divide the retina up into superior temporal, superior nasal, inferior nasal, and inferior temporal quadrants, and kind of comment on the abnormalities in each. Okay, so that was a brief recap. And finally, we've got color vision. So you've got the Ishihara plates, and then you kind of have a look. You ask the patient to read through the numbers. First plate is always a test plate, and you comment on how many of these plates the patient has got right. Okay. So now we'll move on to the red eye sort of presentations, and I'll kind of work from the front of the eye, presentations from the front of the eye to the back. So we'll work through some SBAs for this. So first SBA is a 7-year-old child presents to the ED with erythema and swelling of the right eyelid and periorbital regions. On examination, the area around the eye also feels warm and appears edematous. The patient is noted to have reduced visual acuity in the right eye. What investigations would confirm your suspected diagnosis? Yes, I believe the recording will be made available, Bianca. Oh. Ants, is the screen moving? Let me just see. Can everyone see that now? Okay, perfect. All right, let's have a look at the polls. All right. Is the slide on the SBA now at the moment?
It's on the SBA, but there's no answer yet.
Oh, okay, that's fine. So let's have a look at the polls. 1 second. Ants, have you opened the poll to the SBA 1? Just open the polls for that. All right, so some people have said slit lamp examination. Some people have said swab and culture for sensitivities. Quite a few of you have said CT orbit, and few gone for MRI orbit. So the correct answer for this question, to confirm the diagnosis, is a CT orbit. And so what we're considering here is a child who's kind of come in with redness, swelling of the eye. Also, so you're considering essentially periorbital cellulitis or orbital cellulitis. And particularly the thing that should be ringing alarm bells here is the reduced visual acuity, which is one of the things that you kind of look out for in orbital cellulitis that you won't see in periorbital. And the sort of imaging that would confirm the suspected diagnosis is a CT orbit. The others are valid options. So the swab and culture for sensitivities you could do. Slit lamp examination you definitely will, but the thing that will confirm the suspected diagnosis is a CT orbit. And on the CT orbit, generally what you would see is sort of inflammation of the extraocular muscles. You can see some proptosis there, and there might be some fat stranding as well. I think you can see some there, yeah. All right. In terms of the difference between preceptal cellulitis and orbital cellulitis, we've got, are the slides moving?
Yeah, they're moving.
Okay, good, perfect. So in terms of preseptal cellulitis or periorbital cellulitis and orbital cellulitis, you have something called the orbital septum, and essentially preseptal is before the septum. It's inflammation and infection of the soft tissues anterior to the orbital septum, and this includes things like your eyelid, skin, subcutaneous tissue of the face, but not the actual contents of the orbit. Orbital cellulitis is infection of the fat and muscle posterior to the orbital septum, with the orbit, but not actually, but not involving the actual globe. So the main differentiating things that you should look out for here are the 5 P's. So pain, particularly on movement, on eye movement, or in orbital cellulitis, that should be ringing alarm bells. Periocular swelling, which you can get in sort of both. Pupillary involvement and visual changes. So if there's inflammation of the extraocular muscles, you can get some compression of the optic nerve, which can cause visual changes, and also proptosis. So again, swelling of the extraocular muscles, pushing the eye forward, and you might get a palsy as well in orbital cellulitis. All right, and one of the other things to look out for is also diplopia. So you might get double vision because there's restricted eye movements in orbital cellulitis, whereas that's not the case in periorbital or preseptal. So we've kind of gone through this sort of the differences in each there very briefly, but the main things that you should look out for, again, in orbital are proptosis, pain with eye movement or restriction of eye movements, blurred vision or reduced visual acuity, and diplopia. So if you remember those are kind of the main differentiating factors, and they should ring alarm bells and have you sending this person to get assessed by an ophthalmologist that same day. And don't forget in your history to ask about the systemic symptoms. So even with preseptal cellulitis, you can get a patient who's septic. So don't forget things like your fever, malaise, etc. Just general symptoms of infection. And sometimes you can also get headache with these sort of presentations, particularly orbital cellulitis. So in terms of investigations, you can, as I said, CT sinus and orbit, plus or minus the brain for orbital cellulitis is key in confirming your diagnosis there. In terms of preseptal cellulitis, antibiotics, so coamoxiclav is generally what's given. And if you are worried and you can't really tell the difference between both and you're unsure about the diagnosis, it's always safe to refer to secondary care for further assessment. Better safe than sorry, essentially, if you're not confirmed that it's just preseptal and not orbital. Whereas if it's orbital, you definitely want to send them for urgent same-day assessment by ophthalmology. And that's a key point there for your exams. And IV antibiotics is generally what's given. I think generally what's used, particularly, I know in Birmingham Trust, it's third gen cephalosporins plus or minus metronidazole. But again, local guidelines might differ. I think they're starting to use metronidazole alongside cephalosporins right now. Okay. So, moving on. Just a few key things that might help you, particularly with your exams, is that knowing when to refer. So generally with these, again, if you're unsure of the diagnosis, if they're systemically unwell and they have and you suspect preseptal, still refer immediately. Emergency for a same day ophthalmology assessment. Then you got anyone with suspected orbital cellulitis, children. I think with any, you want to be very careful when you're treating children, so you want to send them for secondary care for some assessment. And if you think they require drainage, or they might have a lid abscess which requires draining, again, refer. So that's preseptal and orbital cellulitis. Let's move on to the next SBA. Thank you, Ants. So a 30-year-old male presents to the GP with a 2-week history of ongoing irritation in both eyes. He mentions that his eyes feel gritty, which is worse in the mornings. And on examination, there is a mild erythema and swelling of the eyes bilaterally. What is the answer here? We've got a couple responses. Just wait a few seconds more. Yeah, all right. Okay, that's all the answers in, and yes, it is warm compress and lid hygiene. And does anyone want to pop in the chat why that is, or what they think the diagnosis is here? Okay, someone's gone for viral. Is that viral conjunctivitis you're saying? Okay. Well, actually, what I was getting at more with this SBA is blepharitis, particularly, yeah, blepharitis. Can present similar to conjunctivitis. So fair enough, that is possible differential. But in this SBA, what I was getting at, particularly with the wording, was that it's bilateral, it's gritty, and it's worse in the mornings. Generally, blepharitis can present with gritty eyes rather than any discharge, watery, or either watery or sticky discharge. Particularly worse in the morning, so they can sometimes wake up and they feel it's quite gritty, sticky, hard to open their eyes. And it's irritation as well. And also the fact that this is bilateral. Generally, blepharitis presents as bilateral. And that's what I was kind of trying to get at in this SBA. And, but yeah, and the warm compress and lid hygiene is essentially the general management for it. So what actually happens in blepharitis is that the etiology is actually unclear, but there are certain causes for it. So there might be meibomian gland dysfunction, which causes lack of secretion of the oil film on top of your tear film. So your tear film kind of evaporates, which causes irritation of the eye, and that causes your sort of grittiness and your sort of grittiness, your stickiness, particularly in the mornings. And also the redness, and you might have a little bit of swelling around the eye. In real life, it's quite difficult to differentiate conjunctivitis or blepharitis, but you can, certain things might point to one or the other. But in this case, blepharitis, because it was more bilateral, grittiness rather than stickiness, and it was in the morning. And with these patients, in terms of treating the actual infection, in terms of treating the blepharitis, it's more hot compress. Eye hygiene is very key. And certain people who might have the causes being dry eyes, you can give them kind of artificial tears as well. But generally, it's hot compress, eye hygiene, and kind of hoping for the best, basically. If it does prolong and it's really affecting the patient, then you can consider ophthalmology referral for further guidance there. Okay, so I kind of saw this SBA somewhere else actually, but I thought it illustrates a very good point. So a 22-year-old female who's presented to the GP with a painful swelling of the eyelid, as shown in the picture below. What is the likely etiology of this presentation? Okay. Give it just a little bit longer. Oh, okay. This is split the poll quite a bit. So there's quite a few of you either going for C or D. We've got some people. Okay, C's going a bit further ahead. Okay. Wait a couple more seconds and then we'll go to the answer. Okay, so we'll go to the answer now. The answer is actually D, so well done for those of you that got that. So it's an oil gland abscess that's caused by Staph aureus. And the kind of two differentials that I was getting at with this question was is it either a sty or is it a chalazion? And the main difference is and the fact that the thing that was kind of pointing towards a sty rather than a chalazion here is the fact that it's painful swelling. So a sty is essentially a kind of walled off collection of pus, essentially, and that is why it's an abscess rather than a cyst, and it's kind of a painful infectious abscess of the oil gland. So it can either be inside, which is in the meibomian glands, or it can be external, which is the glands of Zeiss or Moll, which is kind of represented in the diagram there. So that's either hordeolum externum, which is the external glands of Zeiss and Moll. Then you've got hordeolum internum, which is the inside, which are the infection of the meibomian glands. And whereas a chalazion differs because it's it's not really infectious in origin. It can appear after an infection because of lipogranulomatous inflammation, causing the appearance of a cyst. And that residual cyst is essentially after sort of infection. It's not really painful. And it's generally, it can be a small lump. It can be quite large in some people. I should have mentioned, but it's painless, which is the main thing that you got to note there. And I thought that question kind of illustrated this point quite well. So moving on from here, what the management for these, for both of these, is actually quite similar. So don't need to worry too much about the management. It's generally quite similar. Self-limiting. So the patient should generally get better by themselves. Again, warm compress, eye hygiene. Kind of open up the glands. Open up the glands. Let it drain itself off, and make sure the patient doesn't actually puncture the sty, because that can cause the pus to spread, cause further infection, further styes, etc. And there's also some consideration of antibiotics if there's a concurrent conjunctivitis. So because of infection of the conjunctiva, that can spread to the lid margins, causing infection of the oil glands. And if it's not resolving, then a referral to ophthalmology with incision and drainage can be considered. But generally for your exams, most likely they're going to ask, what's the first line management? Warm compress, eye hygiene is very key. So just kind of remember the difference: painless, chalazion, painful, sty, and so I'm not entirely sure for how long, but I think a few weeks. And if the I'd say a few weeks of eye hygiene and warm compress, if it's still not resolving and it's causing a significant, and if there's no evidence of resolution, it's still getting bigger, and you think that it's your kind of decision. If you think that it's causing a lot of pain to the patient or a lot of discomfort, then you can consider ophthalmology referral in that case. So I'd give it a few weeks and see whether there's actually any improvement with the warm compress and eye hygiene. If it does, if there is improvement, then I think tell them to stick with it, keep going, and it should resolve itself. Most cases it actually does. It's I don't think I don't know if Cameron has any input in that, but I don't think there's too many that kind of go onto ophthalmology for referral. Okay, so we'll hope that answers your question, Liam. So the next question, it's a bit of a long one, but a 30-year-old male presents with bilateral red eyes with sticky discharge for 4 days. The patient last wore contact lenses 1 year ago, and his 7-year-old son recently had the same problem, but it only lasted 3 days. What would you advise in this case? What would be the management or the port of call here? Okay. Right, okay. All right, we got some people going for B, the acyclovir. We got some people most people actually quite going for the chloramphenicol eye drops, so C. We've got some people going for sodium chromoglycate eye drops, and finally we've got a few that are saying take conjunctival swabs. Okay, so for this, the answer is actually prescribe chloramphenicol eye drops. Out of all of these sort of options, this is the most sensible option that you'd go for, and advise the patient to reattend if there's worsening symptoms, so kind of safety net. So does anyone know what we're kind of working with here, what we're considering, if that's the answer, and in terms of the question stem? Anyone? It's fine if not. Yeah, so that's fine. So we're kind of looking, because there's bilateral red eyes, sticky discharge for 4 days, and also this patient has a 7-year-old son, I think who's had a similar sort of problem, but it only lasted a few days. Yeah, that's it. Infectious conjunctivitis, bacterial conjunctivitis in particular is what we're considering here. Exactly. Well done. So, and that's mainly because of the sticky discharge, and the contact that this patient has had with their son. So some of the sort of with infectious conjunctivitis, some of the sort of general signs that you can have are this conjunctival injection. You can have typically unilateral, but also it's typically unilateral, but you can also have bilateral. So don't don't solely base the diagnosis on unilateral or bilateral. Consider some other options as well. And then you've got lid swelling and erythema, and you've got grittiness as well. Clear discharge is particular to either viral or allergic conjunctivitis, whereas bacterial generally, particularly with your generally bacterial will have sticky, like pussy discharge, which you can see in the next slide. So here we've got viral and bacterial conjunctivitis. So generally the difference with viral conjunctivitis, what you're looking for in the history is possibly contacts with people who might have had this sort of thing. You're looking for clear discharge, and they might have a history of an upper respiratory tract infection. And on your examination, try to feel the lymph nodes. They might have periauricular lymph node swelling, and sometimes there's some photophobia with viral discharge. Viral conjunctivitis in particular. Not really sure why, but I've read it in a few places where that's more specific to viral conjunctivitis, I believe. And the causes are commonly adenovirus here. So that might be, again, one of the sort of things that you're asked in your SBAs. Whereas bacterial conjunctivitis, you've got purulent discharge, sticky eyes, and that should kind of pop out to you as bacterial conjunctivitis there, with red eye and also ill contacts again. And the causes are strep pneumo and Staph aureus and H. influenzae, in that order. And generally both are actually self-limiting most of the time. So NICE actually advise not prescribe or to avoid prescribing antibiotics as much as possible. So generally they should resolve within a week or 10 days. Yeah, or would photophobia change your original plan? No, not really, unless it's severe photophobia unless it's quite severe photophobia, in which case you might be considering another sort of diagnosis, but not really, because all the other parts of your examination history would lead you to think of viral conjunctivitis here. Does that answer your question? Because photophobia can actually present in quite a few benign conditions as well. But if it's severe photophobia, then you might consider other sorts of diagnoses, differential diagnoses. Okay, perfect. So management, again, NICE kind of advised to avoid antibiotics. Chloramphenicol drops 2 to 3 hourly can be considered as antibiotics if you do want to prescribe antibiotics, and we'll come on to why in a second. And if you kind of want to avoid antibiotic prescription, then one thing you could do is a delayed prescription. So I guess this is more in an OSCE sort of setting, or if they give you the option in an SBA, you'd select kind of a delayed prescription rather than immediate antibiotics. And general advice is very important for these patients. So try to avoid contact lenses, don't share towels, and also there's no need for school exclusions, which is quite a common exam question, I think. So what was the origin of the bacterial conjunctivitis in the case? The case is the contact lens, even if last year. So, I mean, it was, if I remember, bacterial conjunctivitis in the cases. So if it was a year ago, it's less likely to be it's less likely to be a sort of some like florid infection. Essentially, it's less likely to be something like Pseudomonas or something like that. It's more likely to be the strep pneumo or Staph aureus or H. influenzae, something more common, especially because the patient wore his contacts last used them 1 year ago, and recently he's had contact with his son as well, who's had a similar sort of infection. So it's more likely that this is going to be one of the more common options rather than a like Pseudomonas, for example, even though he is a contact lens wearer. Okay, so moving on to the consideration for antibiotics. If they have purulent, painful, and red eye, then it's always worth considering just giving them antibiotics. If they're a kid as well, if a child comes in, no worries at all. If a child comes in, then you can prescribe antibiotics. I think it's always worth it. You don't it might aid their recovery. And then you also want to consider people who are in contact with other vulnerable people. So people who work with who are carers, ICU workers, nursery workers who are in contact with vulnerable people of the public in general, and also contact lens users. Although in that case, I think I would consider an ophthalmology referral if they recently wore contacts and it's quite a florid infection, then you'd kind of consider an ophthalmology referral. And that brings me on to the urgent ophthalmology review, particularly if you're considering an STI sort of cause for conjunctivitis, for the conjunctivitis, if it's a neonate that comes in with conjunctivitis. And yeah, again, STI risks you want to ask in your history. And also, if they fail treatment, if they're not improving with antibiotics, then you can consider and you're pretty sure that you're thinking conjunctivitis, then you want to send them off to ophthalmology for a review. Okay, and the final type of conjunctivitis that we got is allergic. And what's going to differentiate this generally in your exams is the atopic history. So, yeah, generally allergic history. And also, it'll be sort of cyclical. It'll appear seasonally or monthly or to particular exposures. Will we get the slides and recording? I think Ants said that there'll be a recording. Yeah. So you can get itching, watering, and you can get, and this can generally be bilateral as well. And what you can have is these swollen lids and swollen conjunctiva, as well as a little bit of photophobia here as well. Generally, any sort of inflammation around that area, and particularly if it's affecting the cornea, you can get some photophobia. And what you would do in this case, or what you want to also consider, having a look at the conjunctiva, you might see. Is there a feedback link for today? Yes, there is. There is. It will come through. So there's also chemosis, which is swelling of the surface membranes of the eye, which is caused by accumulation of fluid there. And again, here, basic eye care, cool compression this time, cool compress, and kind of avoid rubbing the eye. In terms of medications that you might consider, so mast cell stabilizers, things like sodium chromoglycate. And in severe cases, there's steroid consideration. But I think at that point, you would want to kind of get input from ophthalmology as well. Okay. So next question. So we have a 50-year-old woman who presents to the ED with left eye pain over the last 48 hours, which is worse at night. And she has a past medical history of SLE and hydroxychloroquine. She's myopic and wears glasses. And on examination, the left eye is deep red and injected throughout. The pain is exacerbated by eye movements. What drop would be most useful to support the suspect diagnosis? Ants, have you opened the poll for this one? Oh yeah, perfect. Thanks. This is to support the suspected diagnosis. Yeah. All right, so we'll move on just in the interest of time. We've got quite a bit to go through. It's phenylephrine drops in this case, so D. And so well done to those that got that. And this is because what we're considering here is either episcleritis or scleritis. And essentially that's because the things that are key in this question are the history of SLE, so a rheumatological sort of condition there. We've got the fact that it's worse at night, so, and also because of the fact that it's pain that's exacerbated by eye movements. I believe the reason why, and what we're considering here is scleritis in particular. So to kind of differentiate from episcleritis and scleritis, you want to put in phenylephrine drops, which blanches the blood vessels in episcleritis. So in this case, if you put the phenylephrine drops on, you wouldn't see the blanching of blood vessels kind of, and you would be thinking more of scleritis. So topical NSAIDs is good for pain management. Prednisolone drops you might need for treatment. Chloramphenicol drops not really indicated here, and with fluorescein eye drops, it wouldn't really differentiate, it wouldn't really differentiate or provide much use in kind of supporting your diagnosis or suspected diagnosis. So, episcleritis versus scleritis. Episcleritis is essentially inflammation of the episclera, which is more superficial, and this can cause kind of mild pain, discomfort. In some patients it doesn't cause pain at all. Actually, mild pain possibly. You can have some watering, some redness of the eye, generally discomfort, but the visual acuity will be completely normal. And also, on examination, if you push the blood vessels with a cotton bud, they're actually quite mobile. And this is because it's quite superficial rather than the deep scleral layer that's affected. Whereas in scleritis, you've got deep, boring pain for these patients. Like these patients will generally be in quite a lot of pain, and it's it can be localized or diffuse red eye, and you might get some blue discoloration because there might be because you might be able to see the uveal layer underneath, essentially, I believe, yeah. And there you can also, and it will also have a sort of subacute or gradual onset to this. All right. So those are the kind of differentiating factors. And when you want to differentiate between episcleritis and scleritis, you put on phenylephrine drops, which kind of blanches in episcleritis. And here you've got kind of a visual representation of these superficial layers of the conjunctiva. So you got and the episclera. So whereas in the sclera you've got more fixed, deep vessels, which is why they're not mobile, and because the inflammation is deeper, it causes more pain essentially there. All right. So moving on, a few associations you need to know with scleritis. You want to think of your rheum sort of background. So you want to think of lupus, rheumatoid arthritis, and IBD. So things like, if you remember, for IBD in particular, the patients might have extragastrointestinal manifestations of anterior uveitis and scleritis. So this is something that you should remember. Whereas with episcleritis, it can actually be recurrent episodes that you've got to remember to ask about in the history. Management, whereas one, you're kind of less worried, self-limiting, so you want to reassure with episcleritis, provide some NSAID drops for pain, and safety net. But other than that, you're not too worried. With scleritis, you want to refer for urgent ophthalmological review in a clinic, in the local clinic, within 24 hours. And you can provide some NSAIDs for pain relief, and steroid drops are usually what you're going to give or what's going to be prescribed to the patient. And you might consider immunosuppressive patients, immunosuppressive agents as well, or oral steroids or immunosuppressive agents, because you want to control what's actually causing the scleritis. Okay, so the systemic cause of the scleritis. Okay. So, does anyone want to pop in the chat what I'm trying to get at, what diagnosis I'm trying to get at with these pictures? So the one on the right is particular to one type of diagnosis, but the one on the left is more generic. Yeah, that's the one on the right. Yeah, absolutely. That's a standard Google stock photo. So yeah, so herpes simplex keratitis is what I was trying to get at with the right picture. The general gist of what I was trying to get at with the whole thing was keratitis in general. So keratitis is the next condition. So it's generally inflammation of the cornea, and what the causes can be either infective, so you want to think of bacterial, amoebic, and parasitic sort of causes. Generally, particular sort of your standard exam, your sort of exam type scenario that they might give is a person who's been swimming in contaminated freshwater, and then has come in with this sort of hazy cornea, reduced visual acuity, a lot of pain, and that might be amoebic keratitis in particular. But general keratitis is inflammation of the cornea. And what you want to do when you see these sort of patients is you want to identify how bad the infection is. If you see a hazy cornea and you're quite worried because you're thinking that the infection is quite deep, and that's because it's affecting the stromal layer, and there's some stromal keratitis or stromal edema there, which is causing that haziness. If it's not hazy, you're a little less worried, but you still want to kind of refer to ophthalmology for assessment for keratitis. And that it's more epithelial there, so on the surface layer. Be aware of contact lens wearers. Make sure they don't put on their contacts again. And if they are contact lens wearers, you definitely want to refer for same-day ophthalmology assessment. And the other thing that can kind of cause keratitis is a foreign body or corneal injury. And a few of the other things that you might be present in, apart from just the hazy cornea or corneal injury, is kind of purulent discharge, and they might have some photophobia again. Okay. And then obviously you treat depending on the course, so antivirals, antibiotics. Okay. So here's a brief diagram of the cornea, which kind of gives you an idea of how deep the infection goes. So you kind of got the epithelium, so that's less worried about. But if it extends to the stroma there, you get some stromal edema, and that causes the haziness that you're seeing. Okay, so next question is, so we've got a 22-year-old male presents to the ED with a painless red eye, as seen in the image below. And I guarantee this will most, if you see an ophthalmology question, this will most likely come up. He mentions that this has come on after vomiting yesterday morning, following a night of considerable alcohol consumption. And the patient is completely well otherwise. What do you think the diagnosis, or what's the appropriate management for this patient? Sorry. And if anyone has any idea of the diagnosis, just pop it in chat. Yeah, subconjunctival hemorrhage. That's the one. And most of you got the right answer. It's send home with reassurance. So this is one of the big learning points. So if you do see this sort of thing come up, subconjunctival hemorrhage, you just send them home with reassurance. And that's because it's a completely benign condition. In the history, you might, subconjunctival hemorrhage. Yeah, well done. You might have coughing, sneezing, or vomiting in the history, and after that, they might develop a burst kind of blood vessel there in the subconjunctiva, and that's causing a sort of bleed. But that resolves by itself within 2 to 3 weeks' time. Things that you would consider asking is also things like, do they have a history of hypertension? Are they on blood thinners? And you might send off bloods for like clotting or something like that. So just be aware of those sorts of investigations. But if there's no cause, or if there's a clear like trigger that you can see, then you can discharge them safely with safety netting. Patients who've had surgery, actually, so things like cataract surgery, can also present with these sorts of red eyes, and they might be quite anxious. So reassurance and send home with safety netting. So next one, we'll move a little bit faster. So a 65-year-old male presents to the ED with a red, painful eye. The patient is also hypermetropic, has a past medical history of rheumatoid arthritis. On examination, there's conjunctival injection and a fixed mid-dilated pupil that's non-reactive. What investigation would confirm your diagnosis? So we'll give 15, 20 seconds or so. If anyone, you can also pop the answer in the chat. I think, Ants, have you opened the poll? Okay, so we've got a bit of a split. Get a couple more responses in, and then I'll reveal the answer. Okay, so what kind of diagnosis that I'm getting at with this SBA was acute angle closure glaucoma, and that's the kind of presentation there on the left eye there. And the answer to this is actually not tonometry. It's actually gonioscopy. I can't really say this word usually. Surprised I got it right. It's because it kind of gives you a direct view of the iridocorneal angle, which is what you want to confirm is closed to confirm your suspected diagnosis of acute angle closure glaucoma. Tonometry you would do as well, and it will show you, and it will most likely show you an increased intraocular pressure. But it's not diagnostic. Diagnostic would be doing a gonioscopy, which would be essentially placing this sort of special lens, which allows you to view the angle between the iris and the cornea. Okay. And the particular factors in the history or the stem that points towards this is the fact that the patient is hypermetropic. So they're more susceptible to acute angle closure glaucoma. And also there's a fixed mid-dilated pupil. Okay. So glaucoma is, I think there's this common misconception that it's linked to, or it's caused by raised intraocular pressure. It's actually a group of diseases that causes progressive optic neuropathy, and it can be associated with intraocular pressure, and it's a key modifiable risk factor. And what actually happens in acute angle closure glaucoma is, if you look at the image on the top right, essentially the iris comes down, and the medial iris kind of comes down, and the distance between the lens and the iris kind of gets smaller. There's a pupillary block, And because of that, there's a buildup of fluid in the firstly in the posterior chamber, which pushes the peripheral iris towards the cornea, and that kind of closes the iridocorneal angle there, and that prevents the drainage of the fluid in the anterior chamber from the anterior chamber through the trabecular meshwork. So there's because of that closure of the iridocorneal angle, which is the main thing that you need to know, there's a buildup of pressure, and that can cause all sorts of that can cause essentially all the things that you're experiencing in acute angle closure glaucoma. And what a patient will present like is with severe pain. It might be ocular, or they might actually have quite severe headache as well. Reduced visual acuity, and this might be due to the stromal edema that they might have. So again, the hazy cornea, and it's particularly worse when people might come in presenting with this onset after they've been watching TV in a dark room because the pupil's dilated, and because it's dilated, there might be a high risk for a pupillary block there. You should also palpate the eye here, and you'll feel that it's quite hard in comparison to a normal eye, and it'll be quite red, and significantly red as well. Other things that people might experience is halos around light, and that's again due to stromal edema. And sorry, the reduced visual acuity could also be because of the optic nerve damage. And finally, don't forget the other symptoms that the patient might be experiencing. So also nausea and vomiting, and sometimes even abdominal pain. Okay, so management of this, I kind of break it down in my head into the goals of management. So either reducing production of the intraocular fluid, or it's increasing outflow. So we got the drugs that we got the topical drugs, so the drops, and then we got the systemic drugs that we kind of give IV. So the main ones that kind of reduce production are beta blockers, so timolol, and carbonic anhydrase inhibitors. And then you've also got the ones that increase outflow, which are the prostaglandin analogs, so lantoprost and pilocarpine, which is the direct parasymptomimetic. So after now we consider the topical drops, we're going to consider the systemic treatments. So that's the IV mannitol you can give, and also, but that's, I think, with senior input, you'd consider giving that. But the thing that you would want to start is IV oral acetazolamide. I think it's generally IV in most kind of exam sort of questions. Okay. All right.
Sorry, guys. I think Nimeshan is just trying to sort his mic just now. So give him a minute or so.
Hello? Can you guys hear me now? Okay, sorry about that. All right, let's get to the slide. Yeah, apologies, there's quite a few. Okay. Okay, lovely, thanks guys. One moment. Okay. So acute angle closure glaucoma. So we talked a bit of management. So we'll move on to the last part of the red eye. I think I'll give you the answer to this one in the interest of time. It's the light. So this patient has come in presenting with history of angst bond. They have a left-sided eye pain, redness, blurring, and this has come over several hours, reduced visual acuity with small pupil, and the fluid level is visible. And what you're considering here is anterior uveitis, and because it's an inflammation, or iritis, as it's also known, and because light and accommodation reflexes kind of causes constriction of the pupils and dilation of the pupils, that causes the patient more pain, because that's the iris is what's affected here. And generally, people with anterior uveitis kind of they'll again be in quite a bit of pain, and this will cause. And what you're looking out for in exam questions is the fact that it's unilateral. They'll have significant photophobia. They will have quite a red eye with injection or redness around the limbus, and also commonly a headache as well. But you also want to particularly look at the history, which will kind of give it away, which are your sort of which I kind of break down as your room factors, your gastro factors, and also infection related factors. So you've got your HLA-B27s or seronegative spondyloarthropathies. Then you've got your SLE and sarcoid, and you've got IBD as your gastro. And then you've got the sort of other infectious causes, which I didn't realize either, actually, until I kind of read into it a little bit more. So TB, HIV, Syphilis and hepatic keratitis can also cause like inflammation of the iris. So investigations, you want to look through a slit lamp, and what you might see in in SBAs are things like cells and flare. So a smoky appearance of the anterior chamber is a flare, and the cells are the little dots you might see. You might see keratic precipitates, which again is a sort of buzzword that you might see in SBAs, but they can look similar to cells on the anterior chamber. And then you can also see an irregularly shaped pupil, which is key again. And can anyone tell me what the little fluid line there is, or what that's called? The little collection at the bottom of the eye, image of the eye there. Yeah, exactly. Hypopion. Perfect. So that's once the cells kind of settle down, they kind of form that fluid level, the hypopion. Again, urgent ophthalmology referral. You need to refer this urgently, and they need to be seen within the next 24 hours. And the goal of treatment from ophthalmology is essentially to reduce inflammation. So steroids are useful here, and also cycloplegic agents such as atropine, which can kind of dilate the pupil and help it relax essentially, and cause and that essentially helps the and that kind of helps the situation there by dilating the pupil rather than keeping it constricted and kind of irregular. And also systemic steroids as well to kind of control what's causing the anterior uveitis. Someone said hyphema. So hyphema is actually a collection of blood, which might be seen there. So that will be completely red. Looks similar to that as a fluid level, but it'll be red, and that might occur with ocular trauma. Okay. So just a quick thing for you guys. If you want to know, can anyone hear anything? Okay, all right. It's a quick thing for you guys. Good place to have a look at all of this is the NICE CKS guidelines for red eye. For the red eye, they give you guidance about what to refer, what not to refer, or what particular to refer. So that's all there if you want to have a look. So here's the feedback before we move on to the next section. And I'll try to move a little bit faster. Okay. Just a few seconds and then I'll move on. Okay, so moving on. It'll be at the end as well, so don't worry. Visual loss is what we're going to cover next. This will be, I'm going to just try and give you sort of structure to triage someone that's come in with visual loss rather than go through every single sort of presentation. We'll try and briefly cover certain things, but it's to give you sort of triage method for visual loss. So what do you want to identify first of all when someone comes in with visual loss is whether their visual loss is monocular or binocular. And this will kind of give you a pathway to go from. And you want to identify if it's monocular, which eye in the history. Always OSCE marks there. So when you have, we'll first go through binocular visual loss. If you have binocular visual loss, then you're considering something in the posterior visual pathways. So something behind, involving the optic chiasm or behind. And you'll either have, generally in most presentations, it'll be either a homonymous defect or you'll have a bitemporal defect. So we'll cover the sort of homonymous defects that you might have. So Generally, these will be behind the optic chiasm with the optic tract. And if you have a lesion in the in the optic tracts, you will have a sort of homonymous hemianopia. Or if you have a lesion in the optic radiations, all the optic radiations, then you will kind of, or which covers Myers and Baum's loop, then you will have a homonymous hemianopia. The other thing that you can have is a quadrantinopia as well, a homonymous quadrantinopia. And this can be because you have a lesion in either Myers or Baum's loop, or either parietal or temporal lesion. And the way, I'm pretty sure quite a few of you know this, but there's an acronym to kind of remember which quadrantinopia goes with which lesion. So if you have a parietal lesion, then you have an inferior quadrantinopia. If you have a temporal lesion, then you have a superior quadrantinopia. Okay, so just a brief one. I think you'll kind of touch base on this maybe a little bit more in neuro as well when kind of cover strokes. Okay, next we'll move on to bitemporal. Bitemporal hemianopias, you will generally have a compression of the optic chiasm. And this can either be from below or above. And generally what you would kind of find is either, generally with exam questions, it could be a pituitary adenoma that's kind of compressing from below, or a craniopharyngioma compressing from above. These are the kind of common exam sort of things. But these are the two sorts of things that you'd kind of consider when it comes to exams. There are other causes, but these are the two that I kind of picked up on. So that's binocular visual loss. If you have monocular visual loss, what you want to do next is identify which eye, and then test the visual acuity. So as we mentioned before, we talked through testing visual acuity. If it's reduced, or you want to see whether it's reduced or normal. If the visual acuity is normal, and someone has some visual loss, monocular visual loss, then you'll consider that the error is most likely due to the peripheral retina. And this could be things like retinitis pigmentosa, which is one of the kind of conditions there, but it also could be something that's shown in the picture on the right. Does anyone know what that is that kind of covers the peripheral retina? That's fine if no one does. That's fine. So it's panretinal photocoagulation, which some people can have if they have extensive hemorrhages in the retina, or laser therapy in the retina. Okay, to kind of stop the bleeding, essentially around there. So that's what you can see. Next, so that's kind of normal. If you have normal visual acuity, you consider peripheral retinal problems. If you have reduced visual acuity after monocular visual loss, then you would kind of do your pinhole assessment to see whether this is due to a refractive error or not. I think we've gone through that already. If it's not due to a refractive error, then what you want to do is you want to assess for if the visual acuity still remains reduced, then you want to check for RAPD. And again, we've kind of gone through RAPD. So once you've tested for that, if there is a relative afferent pupillary defect, then you want to do a fundoscopy to see what in particular is causing the RAPD, and hence the visual loss. And generally, there's two things that will cause this. One is an abnormal retinal appearance that you'll see on fundoscopy. And we'll kind of go through two particular presentations here, and that will cause this. So does anyone know what the one on the left-hand side is? Just pop your answers in the chat. Yeah, exactly. Retinal artery occlusion. So you got a pale retina there. You got the cherry red spot. Yeah, exactly. So you got the pale retina there, the cherry red spot. You got your kind of attenuated blood vessels that you can see on the top left there, and you've also got and you've also got the cherry red spot. Essentially occurs because when you have the CRAO, then you've got kind of retinal edema, and because of that, you can see the underlying fovea, and the fovea actually has its blood supply from the kind of choroid plexus, so it has its own kind of blood supply. So if the central retinal arteries are occluded, then that's not affected, and you can see that red bit of the fovea there. Okay. And finally, what's the presentation on the right? Does anyone know? We've gone for one of the obvious ones. So the next one. No, not hypertensive retinopathy. It's actually, yeah, CRVO. Yeah, that's it. Well done. We've got central retinal vein occlusion. Essentially, you can see your kind of flame hemorrhages. You can see your cotton ball spots, and that's all related to CRVO there. So. And you can also see some of the disc margins there, and sort of stormy sunset appearance. Yeah. Also, one thing to note is that there's quite nicely dilated, tortuous retinal veins that you can see in that picture in particular, which is linked to CRVO. Okay, so just in terms of management for central retinal artery occlusions, it's basically managed as a sort of stroke. So you're kind of ruling out hemorrhages, and you're going to give them aspirin, find the source of the thrombus that's kind of causing the occlusion, and you do all your investigations kind of directed with that. So ultrasound, carotid, echo, kind of hunting for the source of the clot. Okay. And again, these will require ophthalmology referral. So these are just a quick presentation of something that you might see in exam questions. The one on the left is a branch retinal artery occlusion. So only one part of the retina is kind of pale, and the other one's a branched retinal vein occlusion. So you can see the sort of hemorrhages, and you can see the you can basically see the hemorrhages. You can see the dilated tortuous veins on one side and not the other. Okay. So those are the general two that we've got with the abnormal retinal appearance. Next, we've got the normal retinal appearance, which is which you can consider optic nerve pathology there, if you've got a kind of normal retinal appearance. Here we've got optic neuritis. So if someone's come in presenting with poor discrimination of colors, so red desaturation in particular, and it's worse on there's worsening pain on eye movement, then you're thinking of optic neuritis. Something that's specific to this is central scotoma. So it's commonly in demyelinating lesions, such as which can occur in things like MS. And for these sorts of patients, you want to essentially, the management is starting them on high dose steroids to stop or prevent the inflammation from getting worse and kind of settle it down, preventing further optic nerve damage. So it's important to refer these guys immediately for ophthalmology assessment. So the other thing that you want to consider in terms of optic nerve pathology is raised intraocular pressure, which you'll see in primary open-angle glaucoma. So sort of findings that you might find in primary open-angle glaucoma is optic disc cupping. So as we mentioned, the ratio should be 0.3 before. If this is greater than 0.3 as shown in the image, then you're kind of considering the increased pressure causing the cup to get deeper and wider. And then you also might see things like bayoneting of vessels, which is kind of when the vessels come to the optic disc, and because it's quite deep and the cup size is actually quite deep, it will go straight down into the cup and kind of come out at a different place. So it won't look continuous, and that kind of looks like a bayonet, and that's why they call it bayoneting vessels there. And again, for these sorts of things, you want to refer formally for an ophthalmology diagnosis. So when you refer to ophthalmology for primary open-angle glaucoma, they'll do kind of a full assessment involving fundoscopy, a visual fields assessment, so automated perimetry mainly, so not just the fingers and the hat pin. You have an automated perimetry, more specific. You'll measure the central corneal thickness as well, tonometry, measure the pressure of the eye, and gonioscopy, because you want to see whether the iridocorneal angle is open or closed. Okay, so Cameron, if you just want to go through the management.
Sure. So the management, so treatment is usually started at an intraocular pressure of 24 millimeters mercury or above. 360 degree selective laser trabeculoplasty is recommended in NICE guidelines for all patients needing treatment. And that is using laser directly to the trabecular meshwork, and that improves drainage. And then a second procedure may be necessary at a later date. Prostaglandin analog eye drops, an example of that would be latanoprost, are the first line medical treatment. They increase uveoscleral outflow. And then trabeculectomy surgery may be required where other treatments are ineffective, essentially creating a new channel from the anterior chamber through the sclera to a location under the conjunctiva, causing a bleb to be created on the conjunctiva, and then from here it's reabsorbed into general circulation.
Okay, cool. So that's kind of primary open-angle glaucoma in a nutshell. In terms of moving on from there, in terms of visual loss, we've got so we've considered the kind of differential diagnosis or the approach that you take when RAPD is present. When it's not present, you again want to do fundoscopy, and you'll have a look and see what you can see in the retina. If you have a clear view of the retina, then most likely you're going to have a sort of macular pathology, and Cameron will kind of tell us a little bit more about some of the things that can happen there.
Yeah, so age-related macular degeneration is a progressive condition affecting the macula, most common cause of blindness in the UK. It can be unilateral but also bilateral. There are two types, wet and dry. Wet is neovascular and dry is non-neovascular. So drusen are an important finding with age-related macular degeneration. So drusen are yellowish deposits of protein, which are proteins and lipids between the retinal pigment epithelium and the Bruch's membrane. In wet age-related degeneration, new vessels develop from the choroid layer and grow into the retina, so that's what they call neovascularization. These vessels can sometimes leak, causing edema and faster vision loss. And then a key chemical that stimulates the development of these new vessels is VEGF, or vascular endothelial growth factor. And this is the target of medications to treat wet age-related macular degeneration. So the risk factors in this are old age, smoking, family history of it, cardiovascular disease. And the visual changes associated with AMD tend to be unilateral, so gradual loss of central vision, reduced visual acuity, and wavy appearance to straight lines. Wet presents more acutely often than dry. Vision can develop Visual loss can develop within a few days and progress to complete vision loss within a couple of years. And then just when you're examining someone for this, you want to check their visual acuity, which will be reduced. They might have a scotoma, sorry, and enlarged central area of vision loss. And drusen may be found in fundoscopy. You want to do a slit lamp examination to get a detailed view. And sometimes they use fluorescent angiography to give a fluorescent contrast to assess the blood supply. And patients with AMD require specialist ophthalmology assessment. And there's no specific management or treatment for dry AMD. It just involves monitoring and reducing the risk by stopping smoking, controlling blood pressure. And then anti-VEGF meds are used to treat wet. So anti-VEGF will block the VEGF and slow the development of new vessels.
Okay. So the next one is diabetic retinopathy.
Yeah. So diabetic retinopathy would be under kind of diabetic eye disease. It's characterized by damage to the microvasculature supplying the eye due to chronically high blood glucose levels, leading kind of to insult to the retinal cells and deterioration in vision, leading to blindness. Cataracts, cranial nerve palsies are also other complications in ophthalmology related to diabetes. So diabetic retinopathy, the most common cause of blindness in the working age and demographic of the UK. And almost all patients with type 1 diabetes will have some degree of retinopathy within 20 years of their diagnosis. So risk factors, so length of exposure to hypoglycemia, duration since diabetes diagnosis, high blood pressure, so rapid improvement in blood sugar levels. So if you rapidly lower your blood sugar level, it can increase the progression of diabetic retinopathy. So a lot of patients, clinical features of it will be asymptomatic. A lot of these patients only present after developing clinically significant macular edema or having a large vitreous hemorrhage. But it can be picked up on regular eye testing using visual acuity, fundoscopy. It can be classed into different types, 3 classes: proliferative, non-proliferative, and diabetic macular edema. Non-proliferative can be further subdivided to background retinopathy and pre-proliferative retinopathy. And there are different kind of things you should be looking at in these people. So blot hemorrhages on fundoscopy, venous beading, microaneurysms, and hard exudates, cotton wool spots are all things that you'll see and can be questioned in final exams. Proliferative diabetic retinopathy is characterized by new vessels on the disc. And then diabetic macular edema is characterized by oedematous changes or edematous changes in and around the macula. So investigations you want to do HbA1c to see how poorly or well controlled the patient's diabetes is. Fluorescent angiography as well to look at the vasculature of the retina. An optical coherence tomography provides a cross-sectional view of the retina. It's an imaging technique. So medical, managing it, good blood pressure control, good glycemic control, diet, exercise. And in proliferative, photocoagulation is the primary intervention used. Yes.
Okay. All right. So after those sort of presentations that kind of you can see that will cause problems with the macula or have some macular pathology when we're looking through fundoscopy. If you have a hazy sort of retinal view when you're kind of triaging a patient and you have a look through fundoscopy, you're considering something that's occluding your view. So one of the things that it could be is cataracts. Cataracts, leading cause of curable blindness in the world. So very important to identify them. Essentially, it's cloudiness of the lens, gradual opacification as you grow older. It has its certain risk factors that you should know. I think the main ones that you should pay attention to are things like smoking, diabetes, and systemic corticosteroids. one of these sort of exam things that might come up is that systemic corticosteroids could produce a certain type of cataract, and that's a posterior subcapsular cataract. So that's, I don't think you see my pointer, but you can see it in certain diagrams. If you type that in, it will kind of give you a good view of where these sort of cataracts form. Then you got other sort of other risk factors as well, like alcohol, trauma, and UV exposure. So what you do, you can consider it again. As with everything, conservative, medical, surgical. I think here it's mainly conservative and surgical. Conservative, so increase the glasses prescription and encourage bright light when they're reading, or focusing on certain things, particularly with reading, and also referral for it doesn't need to be urgent, but just a referral to ophthalmology to kind of start the process of getting the cataract surgically removed. So the surgery that's kind of done for cataract surgery is phacoemulsification. So they kind of just put in an ultrasound probe into the eye, which kind of breaks up the lens, and then they kind of suck out those bits inside. They kind of suck out the bits of the lens and put in a sort of new lens or an artificial lens that doesn't have a cataract, essentially. So that helps the patient see afterwards. And the sort of complications that can occur in particular that you might be aware of are things like infection, so endophthalmitis, because it's an invasive procedure, posterior capsule opacification or perforation during surgery as well. So they can go through the posterior capsule, which is kind of shown in the images that are there. So probes can go through there, and that can cause some complications. And then some of the other sort of complications that to be aware of are things like retinal detachment, posterior capsule, as we mentioned, posterior capsule rupture already. Okay, so one of the other things that kind of occludes your vision of the retina, apart from cataracts, is a vitreous hemorrhage. So this is kind of sudden, painless visual loss presentation. And when you have a look in or something that patients might complain of is quite a few floaters in particular. I think, yeah, generally quite a few floaters in particular, and they might have a red sort of hue because of the blood that's in the vitreous. And what you got to kind of be aware of in terms of history is that you got to take into account whether they have proliferative diabetic retinopathy causing hemorrhages and bleeding into the vitreous, and also things like posterior vitreous detachment. So as you get older, the vitreous is kind of the vitreous essentially kind of detaches from the retina because it kind of shrivels up essentially. And that detachment can pull on the retina and cause some tears, and that can sometimes cause bleeding, and that causes bleeding into the vitreous humor. Okay. And as with anything, if something bleeds, think of trauma. So ocular trauma, ask about. In terms of management of this, it's an ophthalmology referral is warranted here to kind of get it fully assessed and see what the cause is for this. And if you're seeing them in ED, you can always get a slit lamp out and kind of have a look at the patient, see what you can see with the slit lamp, and you might see some red blood cells in the anterior vitreous. Also, an OCT can be done, optical coherence tomography, which can kind of give you a better image of retina as well to look for any tears. Okay. Next, we're nearing the end, guys. I promise. We got retinal detachment, which is again kind of painless visual loss. Generally, the classic presentation is a curtain-like visual loss from the peripheral retina to the central retina, and what you got to be aware of in history is to try and pick out these sort of patients is flashes and floaters they'll come in presenting with, and then you got to that should ring alarm bells to kind of think of retinal detachment. And especially if they're high myopes, so high myopic prescriptions, you've got to be aware that these kind of patients can have a sort of a retinal detachment. And in terms of management, what determines the management here is whether the retinal detachment involves the macula or whether it doesn't involve the macula. If it doesn't involve the macula, then it is more urgent that you send this patient to or it's more urgent that they have an ophthalmology referral or assessment, and that they have the surgery that's required to kind of correct this, because the outcomes are a lot better, and without the macula coming off, their visual acuity will be preserved more than if a patient has their macula already off during the retinal detachment. So if their macula is still on there, then it is more urgent, and you want to send them off and get assessed by ophthalmology urgently. Macula's off, then a few days, they can wait a few days for their surgery. Macula on, they need their surgery urgently. Okay, I think that's the main kind of takeaway from the management. And certain things that you might see in terms of the exam questions in the slit lamp are pigmented cells or Schaefer cells. So retinal pigment can be thrown up when it kind of detaches. And again, vitreous hemorrhage, as we mentioned, has a link as well. Okay. Again, same day ophthalmology referral. So this is kind of like the triage sort of tree as a whole. So you guys can, once the recording's out, you can kind of have a look at this, and this will kind of give you an idea to how to triage the acute or visual loss, essentially. Okay. So I'll leave it to Cameron to just talk a little bit about diplopia.
Yeah, sure. So diplopia, double vision, kind of happens when there's mismatch in image produced by the eyes. Binocular vision develops because the brain can fuse separate images from each eye into a single image, aided by extraocular muscles, ensuring that both eyes look directly at the same object. If this mechanism fails due to a problem with the ocular muscles or nerves, diplopia occurs. In young children, it will result in suppression of the image, and if untreated, can permanently reduce vision in the affected eye. So it can be divided in different causes: monocular, binocular. So monocular diplopia is typically due to ocular cause, while bilateral diplopia is more commonly caused by neurological or systemic conditions. Monocular diplopia can be caused by corneal irregularities, tears, cataracts. Whereas binocular diplopia, so both eyes, can be caused by neurological conditions, MS, myasthenia gravis, thyroid diseases, vascular causes, strokes. So for the kind of the main part of it, diplopia red flags, you just want to know if it was a rapid onset of diplopia, it can be associated with CNS symptoms, intracranial malignancy, or a vascular cause. If it's persistent, elderly people presenting with diplopia and headache, or sudden onset headache with diplopia. So you want to check on clinical exam, visual acuity, color vision, inspect, do a proper ophthalmic examination. You might want to do some CT or MRI of the brain. You want to check blood pressure and blood glucose. If you have new onset, you should stop driving. Yeah, and it's important to be aware of diplopia because it can be cause of many different things. Having a kind of awareness that it needs to be investigated is pretty important.
Okay. All right, so we're just going to go through one final thing, and that's anisocoria. So this is anisocoria, which is a difference in the pupil size, essentially. And that's due to either the affected pupil being dilated or it'll appear as constricted. And when a pupil is either dilated, when the affected pupil is either dilated or constricted, that's either due to one, parasympathetic innervation disruption, or the second one is sympathetic innervation disruption. So your parasympathetic, to kind of keep it simple, the parasympathetic innervation causes your, parasympathetic innervation kind of causes your pupil constriction. So if it's affected, or if it's not being innervated, then you get a dilation of that pupil. If you have sympathetic, your sympathetic innervation, so your flight or fight a response, you have a dilation of your pupil, usually with sympathetic innervation. If that's disrupted, your pupil will be constricted. So working your way down this sort of tree, if you have a disruption of parasympathetic innervation and your pupil's dilated, you're thinking of either a surgical third nerve palsy or AD's tonic pupil, which is kind of a benign phenomenon of AD's tonic pupil. Whereas surgical third nerve palsy, you're thinking the classic kind of SBA answer to this, or the cause of this, is kind of a posterior communicating artery aneurysm, which is compressing the fibers on the which is kind of compressing the fibers externally, and the parasympathetic fibers externally, and causing that surgical third nerve palsy. And you'll see a down and out pupil here, which I'm sure is covered in your kind of neuro lectures as well. And so again, you'll see a dilated pupil as well. Whereas AD's tonic pupil, it's a benign phenomenon, and you'll see a dilated pupil that contracts in segments. So you'll see like sort of a worm sort of contraction. So different segments of the pupil will contract not in sync. And to kind of differentiate that and to identify this diagnosis, you can use pilocarpine drops, which causes an overconstriction due to denervation hypersensitivity. So because there's a lack of parasympathetic innervation here, put some pilocarpine drops there, that will cause rapid or exacerbated constriction in comparison to the other people. Then we move on to the constricted or sympathetic innervation disruption. So you got your constricted pupils. So you got your Horner syndrome. So ptosis, meiosis, and anhydrosis. You got your different causes of that, but it's just worth to know about Horner syndrome. And you've also got the Argyll-Robertson pupil there. And in particular, to kind of identify and to kind of identify Horner syndrome, you've, aside from the triad, to try and identify what's happening, you can use, I believe it's aproclonidine that you use to kind of identify Horner's. Because, so aproclonidine kind of works because if there's a lack of sympathetic innervation or denervation, lack of sympathetic innervation to the eye, then there is a lot of noradrenaline receptors that kind of upregulated on the postsynaptic membrane. And aproclonidine kind of goes there and binds to these receptors, and that causes a dramatic pupillary dilation. Usually noradrenaline receptors are kind of presented on the presynaptic membrane and cause some mild constriction, which is why if there's no denervation or there's no sympathetic innervation, the lack of sympathetic innervation, then you'll see a mild constriction on application of aproclonidine usually. So simply application of aproclonidine causing massive or dramatic pupillary dilation, thinking Horner's. Application of aproclonidine with mild constriction, normal pupil. And then you got your causes of Horner syndrome. I think so. You got your central, preganglionic, and postganglionic causes. Don't need to know too much about this, but it's just to be aware that this lesions in different areas can cause Horner syndrome. Okay. Just a final point. Does anyone know what this is? or what I'm trying to illustrate with this picture. Final slide, I promise. Okay, so this is papilledema. Due to increased intracranial pressure, you can see that there's bilateral kind of blurring of the disc margins that you can see, and it's only if this is, yeah, exactly, well done, papilledema. It's if it's bilateral and there's a blurring of the optic disc margins there, that you'd say that this is papilledema. If it's unilateral, it's not called papilledema. Just a minor point that that's generally missed, essentially. So that's important to note, particularly with increased intracranial pressure. Okay, so that's the end. Sorry that it took quite a while and we had a few disruptions, but I hope that was useful for you guys. Some of the spot diagnoses that you might want to look at are these sorts of things that you can get in SBAs. So you can have a look at those times and kind of look at these sort of things and kind of Google them in your own time. But yeah, these sort of things that can come up with in certain exam questions. So in summary, I think just learn to identify your ophthalmic emergencies. These are the sort of things that are going to come up in your finals, and have a method to kind of triage your presentation. So I've kind of given you a way to work for red eye, trying to work through your diagnoses using the anatomy of the eye from front to back. And then you've got your differentiating factors there. And then you've got the pathway that I kind of said, to kind of work through visual loss, to identify the sort of differential diagnoses that you're thinking of. And I'm sure you guys will be absolutely fine in your finals. So good luck. This should be a recording that kind of goes up, but here are some references and resources that you guys can use. So Geeky Medics, obviously, nice CKS and BMJ article, which gives you ophthalmic emergencies, gives you an overview of ophthalmic emergencies. Cool. So thank you guys for listening and for staying awake for all this time. But here's the QR code for the feedback for the session, and I believe the next session is ENT, if I'm right, Ants. And if you guys have any questions, floor's open now, or you can kind of email final year Mind the Bleep if you have any questions.
Thank you so much, Nimesh.
No worries.
And Cameron, for that excellent and comprehensive talk on ophthalmology. Yeah, the recording will be up, so you can go back and watch any pieces that you want to review. But I think, yeah, it was a really comprehensive session on the topic. What I'll do is the feedback form's in the chat and also up on the screen ahead of you. But yeah, if you're all right, Nimesh will end the call down below.
Yeah, sure. I know it was a lot of information to take in, but if you guys have any questions, do email the final year Mind the Bleep. We'll try and answer as many questions as we can. Okay. All right.
Thank you.
Thank you.